Let me ask you something that I want you to take seriously for a moment. If you're currently taking amlodipine, losartan, or lisinopril, how much do you actually know about what that pill is doing inside your body right now? Not the general idea, not the vague, it lowers my blood pressure answer. I mean the real, specific, often unspoken things that can show up quietly, build slowly, and catch you completely off guard. Not because your doctor made a mistake, but simply because there wasn't enough time in that appointment to go through all of it. Because here's what I've seen over and over again. People don't usually get into trouble with these medications because they were given the wrong prescription. They get into trouble because they weren't fully prepared for what living on that medication actually looks and feels like. And when the body sends a signal, a swollen ankle, a nagging cough, a dizzy moment getting up from bed, they either panic about the wrong thing or they dismiss something they absolutely should not. Today, I'm going to walk you through 11 things you need to understand about these three medications. Things that often get skipped in a rushed appointment. Things that can prevent a manageable side effect from turning into a real medical emergency. Stay with me. This one genuinely matters. I'm Dr. David Aid, and this is exactly the kind of conversation I believe every patient deserves to have. Before we get into the 11 points, I want you to understand something foundational, and it's the kind of thing that changes how you interpret everything else we're about to discuss. Amlodipine, losartan, and lisinopril are not three versions of the same solution. They are three completely different classes of medication that happen to share one goal: bringing your blood pressure down to a safer level. Amlodipine is what we call a calcium channel blocker. It works by relaxing the walls of your blood vessels so they're not so tightly constricted. Lisinopril belongs to a class called ACE inhibitors. It blocks a hormonal pathway that your body uses to raise blood pressure, called the renin-angiotensin system. Losartan is an ARB, an angiotensin receptor blocker. It targets a similar pathway but at a different step, which is why it's often chosen for people who can't tolerate lisinopril. Same destination, very different roads. And that distinction matters enormously because each road comes with its own terrain, its own bumps, its own warning signs, and its own potential hazards. Once you understand which road you're on, you stop being confused by the signals your body sends. And once you stop being confused, you make better decisions, faster. Let me share a story that I think captures why this matters. There was a woman, I'll call her Gloria, who was 72 years old, organized, diligent, the kind of patient who never missed a dose and always made her follow-up appointments. Her blood pressure improved significantly on amlodipine. On paper, everything looked excellent. 3 months in, she came in and told me her shoes no longer fit properly. Her ankles were puffing up by evening. She felt heavier and sluggish by the end of the day. She thought it was weight gain. Her daughter suspected her heart was weakening. Gloria was frightened, and what no one had clearly explained to her was that the medication working perfectly for her blood pressure was also producing a well-known manageable side effect, one that looks alarming if you don't know to expect it. That gap in understanding is exactly what today's video is here to close. So let's get into it. Point 11. These are three different drugs, working in three different ways. I already introduced this in the opening, but I want to go deeper here because this is the foundation that makes every other point make sense. When you know your drug's class, you know its pattern. Amlodipine, as a calcium channel blocker, relaxes blood vessels by limiting how much calcium can enter the muscle cells that control vessel walls. Less calcium, less tension, lower pressure. But here's the thing. It relaxes arteries more effectively than it assists the return flow through veins. So fluid can gradually build up in the lower legs. The drug is working. The body is just also compensating in a way that shows up as swelling. Lisinopril, as an ACE inhibitor, blocks an enzyme that produces a substance called angiotensin II, a powerful vessel constrictor. Block that enzyme and pressure falls. But lisinopril also affects a molecule called bradykinin, which accumulates when the enzyme is blocked and can irritate the airway lining, producing that famous dry, persistent cough. Losartan, as an ARB, goes one step further down the same pathway. Instead of blocking the enzyme that creates angiotensin II, it blocks the receptor where angiotensin II lands. Same effect on blood pressure, but it does not accumulate bradykinin the way ACE inhibitors do, which is exactly why losartan is often the preferred switch when someone develops that lisinopril cough. Here's the practical implication of all this. If you develop a cough on lisinopril and assume that means all blood pressure medicine makes you cough, you might stop treatment entirely. If you swell on amlodipine and assume your heart is failing, you might panic unnecessarily. If you feel comfortable on losartan and assume there's nothing to watch for, you might miss a slow potassium problem building in the background. The name on the bottle tells you the class. The class tells you the pattern. And knowing the pattern is what separates a prepared patient from a frightened one. Point 10. That ankle swelling may not be what you think it is. This is one of the most misread side effects in blood pressure medicine, and it's one of the most common with amlodipine specifically. People assume the swelling means they've eaten too much salt, or their kidneys aren't keeping up, or they've become too sedentary, and sometimes those things are true. But when someone on amlodipine notices that their socks leave marks in the afternoon, that their ankles look different by evening than they do in the morning, and that sleeping with their legs elevated gives them some relief overnight, the explanation is almost always the medication. Here's the mechanism. Amlodipine dilates arteries more readily than it assists venous return. Blood flows into the legs with less resistance, but has a harder time flowing back up. Pressure builds in the small capillary vessels, and fluid leaks out into the surrounding tissue. It is not kidney failure. It is not heart failure. It is a vessel tone mismatch. I want to tell you about a man I'll call Arthur. He was 76. Every afternoon his ankles were noticeably larger than they'd been in the morning. He had started elevating his legs before bed and noticed improvement, then figured the pattern was just age catching up with him. He never connected it to the amlodipine he had started 6 weeks prior. What made this situation truly dangerous wasn't the swelling itself. It was the silence around it. Arthur didn't want to seem like he was complaining. He started skipping doses on days he planned to go out, because he was self-conscious about how his legs looked in public. And that's how a tolerable side effect becomes uncontrolled blood pressure. Swelling on amlodipine doesn't automatically mean the drug is wrong for you permanently, but it absolutely means the conversation needs to happen. There are dosage adjustments, complementary medications, and in some cases alternative drug classes that your clinician can explore. What it cannot be is something you quietly manage alone by skipping doses. Point 9. The cough that arrives late and gets blamed for everything else. If there is one side effect associated with lisinopril that patients most often miss, or rather, most often attribute to something else, it is the dry, persistent cough. And here's what makes it so easy to miss. It doesn't always begin right away. Some people notice it within days, others within a few weeks. And for some patients, it develops after several months, which is exactly the kind of timeline that breaks the connection in people's minds. By the time the cough starts, they've already settled into their medication routine and stopped thinking of it as the new variable. The cough usually feels scratchy and irritating. Not wet, not productive, not dramatic, just relentless. And because it tends to worsen at night, people assume the problem is their lungs, their reflux, seasonal allergies, or dry air. They buy lozenges, they change their pillow, they start humidifiers. Nothing helps, because the trigger is biochemical, not environmental. I'll share the story of a woman I'll call Helen. She was 69. About 4 months after starting Lisinopril, a persistent throat irritation developed. Then came nighttime coughing that disturbed her sleep and left her exhausted during the day. She assumed it was reflux returning and changed her diet. She tried everything except the one thing that would have helped, recognizing that the cough was almost certainly medication-related. When I asked her to compare the timing of the cough's onset with the timing of her medication start, she was genuinely stunned. She had simply never been told the cough could appear that late. Now, and I want to be very clear about this, a dry cough on lisinopril is not the same as a medical emergency. It is annoying, it can disrupt sleep, and it is a legitimate reason to have a frank conversation with your doctor about switching to a different class. Losartan, as I mentioned, is often a very appropriate alternative, but there is a separate symptom that is an emergency. And I need you to hear this part carefully. If you experience sudden swelling of the lips, tongue, face, or throat, especially if you feel any difficulty breathing or swallowing, that is not a wait until Monday situation. That is not a call the office when they open situation. That is, go to emergency care right now. ACE inhibitors like Lisinopril can, in rare cases, cause a reaction called angioedema, a rapid, sometimes severe swelling of tissue that can compromise the airway. It is uncommon, but when it happens, it can escalate quickly. ARBs like Losartan have a much lower risk of this, but the possibility is not entirely absent. Cough. Monitor, report, discuss a switch. Tongue or throat swelling with breathing difficulty. Emergency. No delay. Knowing that distinction can genuinely save a life. Point 8. The potassium problem that hides in your kitchen cabinet. If you take Losartan or Lisinopril, potassium is not just a number on a lab result. It is an active safety variable, and one that is surprisingly easy to push in the wrong direction without realizing it. Both of these medications can cause the body to retain more potassium than usual. In most healthy people on normal diets, this is not an immediate problem. But in certain situations, particularly if potassium is also coming in from dietary sources or supplements, levels can climb to a point where the heart's electrical rhythm becomes affected. The tricky part is that potassium doesn't only come in a labeled supplement bottle. It hides in salt substitutes, in heart-healthy seasoning blends, in electrolyte powders marketed for hydration, in certain protein drinks. Many people who are actively trying to be health conscious are inadvertently stacking potassium without realizing it. I think of a patient I'll call Robert, 74 years old, recently motivated to take better care of his health. He reduced sodium carefully, switched to a salt substitute because he'd read it was better for the heart, and started using it liberally. What he didn't know was that most sodium-free salt substitutes achieve their flavor by replacing sodium with potassium chloride. So every sprinkle of his heart-healthy substitute was adding potassium on top of the potassium already being retained by his Losartan. He began feeling weak and slightly off. He noticed occasional skipped beats. When his labs were finally checked, his potassium levels were high enough to require prompt management. Robert wasn't careless. He was trying to follow all the rules. The problem was that no one had connected the dots for him between his medication, his new dietary habits, and a genuine lab risk. High potassium, a condition called hyperkalemia, doesn't always make itself loudly known. It can present as muscle weakness, cramping, a pins and needles sensation, unusual fatigue, palpitations, or sometimes barely any symptoms at all. And it can affect the heart in ways that are serious. If you take Losartan or Lisinopril, your conversations about diet need to include potassium, not just sodium. And anytime you're considering adding a supplement, a salt alternative, or a nutritional product that emphasizes electrolytes, that is worth a mention to your pharmacist or clinician before you begin. Point 7. A lab number. That moves is not always a lab number that's alarming. This is one of the most misunderstood aspects of being on Losartan or Lisinopril, and it's the one that causes patients to make some of the most consequential, impulsive decisions. Both of these medications can cause a small shift in kidney function markers. Specifically, creatinine may rise slightly, and eGFR may dip a bit when you first start the medication or when the dose is increased. To a patient who receives that lab result via a portal notification before anyone has had a chance to explain it, this looks like evidence that the drug is damaging the kidneys. Here's what's actually happening in many cases. These medications alter the pressure dynamics inside the kidney's filtration structures. That shift can produce a temporary change in certain lab values, not because the kidneys are being harmed, but because the filtering pressure itself has changed. In the right patient, this is not only expected, it may be part of how the medication protects the kidneys long term. I'll tell you about a woman I'll call Sharon. She was 71, with both hypertension and early-stage kidney disease. Her doctor had started Lisinopril specifically because, in her situation, it had the potential to slow kidney deterioration over time. A few weeks later, her follow-up labs showed a small change in her kidney markers. She saw the results online before her care team had called, and she was one decision away from stopping the medication that evening. When we spoke, the key question wasn't, did the number move? The question was, how much did it move? In which direction is the overall trend heading? And what is the full clinical picture? A small expected shift under careful monitoring is very different from a significant progressive decline that demands action. The role of lab follow-up is not administrative paperwork. It is part of the treatment. It is how your clinician determines whether what's happening is acceptable adaptation or a concerning trend. Never stop these medications because a lab result looked different without speaking to your care team first. The interpretation of that number belongs in a clinical conversation, not a patient's moment of late-night anxiety. Point 6. What happens when illness changes the rules? Here is something that does not get said clearly enough, and it has led to some genuinely frightening situations for patients who were doing everything they thought was right. If you are on Losartan or Lisinopril, and to some extent Amlodipine, and you become ill with vomiting, diarrhea, a significant stomach virus, or you experience heavy sweating and extreme heat, the medication that was working appropriately for your body yesterday may behave very differently today. These drugs help regulate blood pressure partly through their effect on fluid dynamics and blood vessel behavior. When your body loses significant fluid, that internal environment shifts. The same dose that was calibrated for a well-hydrated body can now drop blood pressure too low, put excessive strain on the kidneys, and cause dizziness, weakness, or fainting. In some cases, especially in older adults, this can accelerate into acute kidney stress faster than most people would expect. The medication did not suddenly become dangerous. The body's fluid status changed, and that changed the context the medication is operating in. I think of a man I'll call Frank. He was 78 and had a bad stomach virus. Couldn't keep food or water down for most of the day. He was proud of never missing a dose, so he took his Losartan the next morning as usual. That evening he stood up from the couch and the room tilted sharply. He caught himself on the edge of a table, but barely. In the emergency department, his blood pressure had dropped significantly, and his kidney markers showed stress. The Losartan wasn't a bad drug. The problem was that nobody had ever told Frank that his usual medication routine needed a modification plan for sick days. And that illness is exactly the kind of situation where the rules can change, and the usual routine may need to pause until you get guidance. If you ever become significantly ill, fever, prolonged vomiting, heavy diarrhea, or anything that leaves you unable to stay hydrated, that is not a take the pills anyway and push through situation. That is a call your clinician or pharmacist today situation. Ask what to do with your blood pressure medications while you're unwell. Having that conversation in advance, before an illness happens, is even better. Point 5. The over-the-counter combination that can quietly harm the kidneys. If you regularly take ibuprofen or naproxen for arthritis, back pain, joint discomfort, or any kind of chronic ache, and you are also on Lisinopril or Losartan, particularly alongside a diuretic, this is a combination that deserves serious attention. Anti-inflammatory pain medications in this category, called NSAIDs, affect the kidney's blood flow regulation. In isolation, for a healthy person taking them occasionally, this is usually not a major concern. But for someone already on a blood pressure medication that also influences kidney circulation, and possibly a diuretic on top of that, the combination can significantly reduce blood flow to the kidneys. Add dehydration to the mix, and the risk climbs further. The challenge is that people often don't mention over-the-counter pain medication to their doctor because they don't think of it as real medication. It's from the drugstore. It's available to anyone. Surely it can't be part of a complicated medical picture. I want to tell you about a woman I'll call Carol. She was 73. She took lisinopril for blood pressure and a water pill for leg swelling. She also used ibuprofen several times a week for arthritis in her hands, something she'd done for years without incident. She thought of it as a minor background habit. Over time, her kidney markers began drifting in the wrong direction. Her blood pressure became less stable. No one could immediately identify what had changed in her treatment, because the ibuprofen had never been listed in her medication history. It was only when a thorough medication review uncovered the full picture that the pattern became clear. Once the daily anti-inflammatory was removed and safer alternatives for her arthritis pain were found, her kidney numbers stabilized and her blood pressure became more predictable. The lesson here is not that ibuprofen is forbidden, it's that ibuprofen is not casual when combined with these medications, especially over time, especially with dehydration, and especially when a diuretic is also in the picture. If you use pain relievers regularly, that needs to be part of the conversation with your care team. Ask about safer alternatives. Ask how often is safe. This is not a minor footnote. It is a real safety priority. Point 4. The side effect. People laugh off until someone gets hurt. Mild dizziness, a moment of lightheadedness when you stand up too quickly. A slightly unsteady feeling in the first few days on a new dose. People describe this and then wave their hand and say, "Oh, I just stood up too fast." Maybe. But in older adults especially, a few seconds of dizziness is not just uncomfortable. It is a fall risk. And falls in older adults can mean fractured wrists, head injuries, broken hips, injuries that can have serious long-term consequences. All three of these medications can cause low blood pressure effects when first starting them, or when the dose increases. This happens because the medication is doing its job, lowering pressure. But the body's adjustment can take a little time. The brief drop when transitioning from lying down to standing is called orthostatic hypotension, and it's a real, physiologically understandable event. But that explanation doesn't make it less dangerous when it happens at 2 in the morning on the way to the bathroom. I think of a man I'll call Joseph. He was 80, lived alone, and carried himself with great pride in his independence. 2 days after moving to a higher dose of amlodipine, he stood up from the bathroom in the middle of the night and felt the world tilt sharply. He grabbed the sink just in time. He hadn't fallen, but it scared him. And when I asked whether anyone had talked to him specifically about rising slowly, sitting at the edge of the bed first before standing, and watching carefully for any persistent dizziness or near-fainting events, he shook his head. He had been told the medication would lower his blood pressure. He had not been told what that might feel like in a real body moving through a real house after dark. That is the difference between explaining a prescription and truly preparing a patient. Mild, transient dizziness that improves within the first week or two as your body adapts is usually manageable. Repeated dizziness, near-fainting episodes, or weakness that persists, that is not something to silently endure. It is something to report promptly. Point 3. A single. Reading is a snapshot, not a verdict. This is where many otherwise intelligent, attentive people accidentally create problems for themselves. They check their blood pressure, see an elevated number, and decide the medication is failing. Or they see a low number and panic that the medication is too strong. Then comes the dose adjusting, the extra tablets, the skipped pills, all based on a single moment in time. Blood pressure is not a static measurement. It rises and falls constantly throughout the day, responding to sleep, stress, caffeine, a salty meal, emotional conversations, posture, pain, and even the anxiety of measuring itself. A single number read in an agitated state after rushing to the bathroom does not represent your treated blood pressure. It represents one data point under specific circumstances that were not designed to produce an accurate reading. What matters is pattern. What matters is consistency. What matters is a trend observed over time, under reasonably standardized conditions. I think of a woman I'll call Diane, 67 years old, diligent and health conscious, who checked her blood pressure every time she felt anxious, if she read a concerning headline, if she had a headache, if she had a stressful phone call. And whenever the number was high, she measured again, and again, and again, until she had a page full of numbers and a mind full of fear. She was convinced her Lisinopril was not working. But when we introduced a calmer protocol, same time of day, 5 minutes of quiet rest, the same arm, the same position, a very different picture emerged. Her medication was doing a reasonable job. The problem was not the medicine, it was the method. Good medicine plus poor interpretation produces poor outcomes. The number on the monitor is only meaningful when the measurement is taken correctly, consistently, and interpreted in context. If your readings concern you, bring them, all of them, with dates and times, to your next appointment. Let your clinician see the full picture before any changes are made. Point 2. These are long-game medications, not rescue pills. One of the most important behavioral truths about amlodipine, Losartan, and Lisinopril is this. They are designed to work through steady, consistent daily use. They are not emergency medications that respond to crisis. They build their effect over time, and they maintain that effect through routine. When people miss a dose, the instinct is often to make up for it by doubling up later, or to take an extra tablet when the home monitor shows a spike. These decisions feel logical in the moment, protective even, but they can produce abrupt drops in blood pressure that cause dizziness, weakness, and falls. They can create unpredictable swings that make your overall control worse, not better. Standard guidance for most of these medications is straightforward. If you miss a dose and remember it reasonably soon, take it. If it's nearly time for the next dose, skip the missed one and resume your normal schedule. Do not take 2 doses together to compensate. Do not take an extra tablet based on one high home reading. I want to tell you about a man I'll call Martin. He was 75 and genuinely committed to his health, but his relationship with his Lisinopril was anxiety-driven. If he forgot the morning dose and remembered at lunch, he'd take it then. If he remembered again mid-afternoon, he might convince himself a second one was safer, just in case. Once, after a high reading, he took an extra tablet before bed to protect himself overnight. The next morning he felt washed out, dizzy and deeply unsteady. He hadn't been reckless. He had simply never been taught the one truth that governs all 3 of these medications. They are not for managing spikes. They are for building a stable baseline. They need you to be consistent, not reactive. If you're unsure about what to do when you miss a dose, ask your pharmacist. It takes 2 minutes and could prevent a very unpleasant day or, in an older adult, a dangerous fall. Point 1. The best medication is the one you can stay on, safely and knowingly. Everything we have talked about today leads to this. The metric that matters most when evaluating your blood pressure medication is not the reading on the monitor 3 weeks in. It is whether you can stay on this medication safely, consistently, and with full understanding. Over months, over years, over the long haul. A medication can produce a beautiful number on paper while failing in the real world because the person taking it doesn't understand its warning signs or hates how it makes them feel or has quietly started avoiding it without telling anyone. Amlodipine may be ideal for one person and cause unacceptable swelling for another. Lisinopril may protect kidneys and control pressure exceptionally well, while a relentless dry cough slowly erodes someone's sleep and their willingness to take the pill. Losartan may be the perfect middle ground, but it still demands respect for potassium, kidney monitoring, and hydration during illness. I want to tell you about a woman I'll call Teresa. She was 70, and her blood pressure numbers on Lisinopril were genuinely excellent. Any clinician glancing at her chart would have felt satisfied. But Teresa was coughing every night, sleeping terribly, and had begun to dread the pill. She never brought it up because she assumed the response would be, well, you need it, so find a way to live with it. That assumption, that side effects must be silently endured in service of a good number, is exactly where patients begin to disappear from their own care. First, they resent the medication. Then, they start forgetting it intentionally. Then, they stop entirely. Then, the blood pressure rises, and everyone is surprised. Teresa didn't need to be told to push through. She needed a medication plan that fit her actual body and her actual life. And once the cough was identified as likely medication-related, her clinician was able to reassess and adjust her treatment accordingly. That is what good care looks like, not a prescription defended at all costs, a prescription that serves the person taking it. Side effects are not personal weakness. They are not evidence of failure. They are data. Ankle swelling is data. A persistent cough is data. Dizziness is data. Cramping and weakness are data. And your role, as the person living inside that body, is to notice the pattern and bring it forward, not to diagnose yourself, not to manage it alone, but to speak up early, clearly, and without waiting until something minor has become something serious. Silence is not strength when you're on powerful medication. Silence is how manageable problems grow into crises. Let me leave you with a clear framework to carry forward. If you take amlodipine, watch for ankle and lower leg swelling, especially if it worsens through the day and improves overnight with elevation. Also watch for headaches in the first few weeks, flushing, or dizziness when changing positions. These are common and often manageable, but they deserve a conversation. If you take Lisinopril, know that a dry, persistent cough may arrive weeks or even months after starting the medication. Report it. It is a legitimate reason to discuss alternatives. And memorize this clearly. Sudden swelling of the lips, tongue, or throat with any difficulty breathing is an emergency, not a side effect to wait out. If you take Losartan, pay attention to how you feel during illness or heat-related dehydration. Be aware of what you're adding to your diet in terms of potassium, including salt substitutes and electrolyte products. Watch for muscle weakness, cramping, tingling, or irregular heartbeat, and bring those symptoms to your care team promptly. Keep your scheduled lab appointments. They are not optional. For all 3, Consistency in how you take the medication matters enormously. Blood pressure readings matter more as trends than as individual snapshots. Over-the-counter pain relievers, particularly ibuprofen and naproxen, are not casual additions when you're on these medications. And any symptom that you cannot explain is worth a conversation, even if you're not sure it's significant. You don't need certainty to make a phone call. You need a pattern that concerns you. I want to leave you with one final thought. There are millions of people right now taking one of these 3 medications, people who know the name on the bottle and the number of pills to take each morning, but who are operating in a kind of informational fog about everything else. They don't know why the ankle swelled. They don't know why the cough won't stop. They don't know why their lab results changed. They don't know that the salt substitute on their table or the pain reliever in their cabinet could matter. That fog creates fear, and fear creates bad decisions, either catastrophizing manageable symptoms or dismissing serious ones. The moment you understand how your medication actually works, what it's doing, what to watch for, when to call, and when to wait, so much of that fear dissolves. You stop seeing every symptom as catastrophe, and you stop pretending obvious warning signs mean nothing. That balance, informed attention without panic, is where safety lives. You are your own first line of defense, not your lab results, not your monitor reading, not the name on the bottle. You, paying attention, speaking up, and being an active participant in your own care. That is what I believe every patient deserves, and that is what this channel is here to support. If this video gave you something useful, please share it with someone taking blood pressure medication, a parent, a sibling, a friend, because there is a very good chance they need this information too, and they may not know to look for it. Like this video, subscribe so you don't miss what's coming next, and leave a comment below telling me which of the 11 points surprised you the most. Your response genuinely helps me understand what to cover next, and it may help someone else reading the comments find exactly what they needed to hear. I'm Dr. David Aid. Thank you for being here. Take care of yourselves, because you absolutely deserve to.